This program is brought to you by Stanford University. Please visit us at stanford.edu.
I'd like now to introduce tonight's speaker, Dr. Robert Robbins, and tell you a little bit about his background, which I must say is a daunting task because his resume is literally 75 pages long. He was born and raised in a small town in Mississippi, had fantasies of playing football at Ole Miss and then going on to be a pro player, started out in a small community college because they did a great job training athletes, but then decided maybe he wasn't going to make the pros. So he went to a small college, Millsaps, also in Mississippi, to get his degree in chemistry. From there, he went on to Ole Miss, but not as a pro football player, but as a medical student. And he graduated there with his medical degree, did his internship and his residency there. He then went on and did postdoctoral fellowships at a couple of other places, including Emory and Australia. And he came to Stanford as the chief resident of cardiothoracic surgery about 15 years ago. All in all, Dr. Robbins has trained to become a heart surgeon for almost 20 years. He's now one of the world's most renowned cardiothoracic surgeons, and he's also called upon by colleagues around the world to advise them in treating a variety of very complex cardiac diseases. He performs 20 or so heart transplants a year, and in addition to his talents as a doctor and a researcher, his leadership qualities and his vision for the future of medicine quickly became recognized. In the past 14 years, since he has served as chief resident in cardiothoracic surgery, he has gone from being an acting assistant professor, an associate professor, a full professor, and now chairman of the cardiothoracic surgery department. In addition, he simultaneously is director of Stanford's new multidisciplinary Institute for Cardiovascular Medicine. He is director of the Cardiothoracic Transplantation Lab, and he is co-chair of the Cardiac Clinical Center. As is true for all of our summer speakers, Dr. Robbins happily agreed to talk to you tonight with absolutely no compensation, and his incentive is just to help to inform and inspire our community about heart disease and the new ways that we have of treating them. So please give a warm welcome to Bobby Robbins.
Well, this is going to be a lot of fun. Pat and I shared a great friend, Norman Shumway, and I'm tempted to use one of his lines, and I guess now I will, that, you know, it was like listening to my eulogy. So this is a lot of fun for me. I'd like to start by thanking all of you for taking time out of your busy schedules to come out tonight to listen to me, and specifically thank Pat for inviting me to come out. She's got nice weather for us, and I hope this will be fun and informative for you. It's a lot of fun for me because I don't have to drag my laptop and worry about slides and AV and pointing and all that. I just get to talk to you. There's a little test here. Pat, I asked Pat, you know, are you one of the Devaneys? And she said, what does that mean? And I said, you know, are you related to Bob? How many people know who Bob Devaney is? See? Yeah, Matt Doyle back there, Director of Football Operations at Stanford, now knows who Bob Devaney is. So it was great fun to chat with Pat about her dad, who is a legendary figure in Nebraska football. So, and if you didn't catch Mike Longacre, you should go and I guess it's a podcast that you can download, because he talked a lot about stem cells and regenerative medicine, and I'll mention a little about that. But if you want to know more about it, he gave a great lecture recently about that. There's a little 6 degrees of separation going on. He played on a national basketball team at Michigan State, and Pat's dad coached at Michigan State. So there's a little connection there. So we'll get off the sports now and start talking about medicine. What I'm going to do is I'm going to talk about some basics of the heart. Pat asked me to define what cardiothoracic surgery is. Well, cardiac is the heart part. Thoracic is lungs, the esophagus, the feeding tube, and structures in the chest cavity. So think of cardiothoracic. The heart and the lungs are inextricably linked together, obviously. And then there's cardiovascular medicine and surgery, and vascular has to do with blood vessels. So those are kind of the starting terms. And I thought, this would be a kind of a basic review of the heart to talk about what the heart is and what potentially can go wrong with the heart. So the heart is just a big muscle. It's not like the brain. It's not complex. It's not wired and does magical things. It just pumps blood. It's a big muscle. So the way that the blood gets to the muscle to provide function is through the coronary arteries. And I'll come back to each one of these components of the heart and talk about things that can go wrong and what's new and how we're treating different parts of the heart that can become diseased. In addition to the four chambers of the heart, the right chamber pumps blood to the lungs that gets oxygen in it, brings it back to the left side of the heart. It's then pumped out to the body to provide oxygen and nutrients out to the body. There are, think of the chambers of the heart as rooms, and there are doors between each room, and they're one-way doors, and those are called the valves. The two most important valves are on the left side of the heart, the mitral valve and the aortic valve, and they can become diseased, and we'll talk about some of the ways that they can be treated. Think about these valves one way. If you ever have been across these sort of gates that have the spikes that say "Don't back up" or "Your tires," I've always wanted to do that to see if it would actually. Has anybody ever done that? Does your tire actually go flat? So think about the valves in that way. Then the heart is wired with an electrical circuit, and so there are electrical abnormalities that can occur with the heart. The big blood vessel that comes out of the left side of the heart is called the aorta. So there are diseases called aneurysms, which are ballooning or enlargement of the aorta that can be affected. And then finally, you can be born with holes in the heart, and those are congenital lesions. So that's how I kind of separate the 6 parts of the heart. It's like a motor. I heard recently someone say, it's a fun little game you can play that, I'm going to give you a word and think about automobiles. And if you think about performance, what word comes to your mind? Well, a lot of people would say BMW or Porsche or Ferrari. And if you think about safety, most everybody would say Volvo. So think about the heart as being not only a high-performance muscle, but also it's safe. But with any kind of high-performance vehicle, you have to take care of your heart and provide good maintenance. And we'll talk a little bit about that toward the end, about what things we can do to prevent heart disease. And I think you know a lot of them, and we can get into more discussion about that in the question and answer session. So let's start out with coronary artery disease. I'm assuming that most of you are coming here tonight because you've either had some sort of cardiovascular disease, or you know someone, or have had a family member with coronary artery disease or some sort of heart disease. And 1/3 of the people in the United States that die will die from some cardiovascular complication, primarily from heart attacks. About 25% will be from heart attacks, and about 7% from stroke. If you put those together, it's about 35% of all deaths in the U.S. are from some form of cardiovascular disease. About, in comparison, about 22, 23% would be from some form of cancer. So it's a major problem in the United States. And of course, things are getting better, but it's still a major problem, and that's why we're talking about it tonight. So let's start with the coronary artery, which takes the blood flow down to the heart muscle itself. And you can get blockage of the coronary arteries, and that's called coronary artery disease. And the way that we treat that is either with bypass surgery, which is what I do, or the cardiologist can go in with a catheter threaded up the aorta and do blow up a balloon to open the blockage and then put a stent in place. So as time has gone on, the development of cardiac surgery, in particular bypass surgery, is about 40 years old. And just to take you through how a heart operation is done, and as we get further along in this and I talk about transplants, you'd say, well, now how in the world could you take someone's heart out? What happens? How do they stay alive? Well, they stay alive with a heart-lung machine. It's called cardiopulmonary bypass. And it does exactly what the name says. There's a pump with tubing where blood drains out of the right side of the heart that doesn't have enough oxygen in it. And then it's pumped through a membrane, which is the lung part of the heart-lung machine. And then blood goes back into the aorta, and we put a clamp on the aorta so that we stop the heart. And we keep the heart cold so that we preserve that muscle so that it'll beat after we start the heart back up. So that's cardiopulmonary bypass, or the heart-lung machine. And that was developed about 50 years ago. So we've been doing heart surgery for about 50 years. It started out more with congenital heart surgery and then coronary bypass. So that has been the mainstay of how one treats blockages in coronary arteries. And as we've developed techniques and enabling technologies to do bypass surgery, we started doing the operations oftentimes through smaller and smaller holes. Now we can do through a small incision in the left side of the heart. Traditionally, we do heart surgery by a long incision through the front. I saw one of my patients here. We joked that he can come up and pull his shirt up and show you his scar if you really want to see what it looks like. But it's about a foot-long scar, and we have to saw the breastbone, the sternum, in two to do the operation. We're developing techniques now through small incisions in the lateral part of the left chest to use a robot to take down the mammary artery, use an artery from the arm, the radial artery, where you take your pulse. You can actually take that out, sew it onto the side of the mammary artery, and with the heart beating, we have little stabilizers that allow us to hold the heart still, open the coronary artery, and sew the vessel in place. So as we've gotten more and more or less invasive, the cardiologists have gotten more and more invasive. They're now doing more procedures to clean the arteries out, to put stents in, and a major advance in the use of stents has been drug-coated stents. Now there's some controversy about that, and that is that these drug-coated stents require Plavix. I went, my hair was looking a little shaggy, and because I found out they were videotaping this, I thought I might go get a haircut. And so I was with my barber right here on campus, and I was talking to him. He said, "You're the heart guy, right?" And I said, "Yeah." And he said, "I remember when I first met you, I said, you're a cardiologist." I said, "No, I'm not a cardiologist, I'm a surgeon. And I'm the last guy you want to see, because if I get a hold of you, you're gonna have a little pain, and I'm gonna give you a big incision." And he said, the funniest thing happened. About a month ago, I woke up at 3 o'clock in the morning with crushing chest pain. I had to get my neighbor to rush me down to the hospital. I got into the emergency room. My heart stopped. It fibrillated. I had to be shocked. I was taken to the cath lab. I had a completely blocked coronary artery, and I had a stent put in, and I was back to work in 3 days, and I feel great. He said, "But I don't understand it. I'm 47 years old, and I'm in great shape. Why did that happen to me?" And you know, you just have to start talking for a few minutes, and you can find somebody, either a father, a grandfather, an uncle, somebody in the family. And then he said, "Oh yeah, my mother had this done, but she paid attention to her symptoms. He'd been having symptoms for about a month." So one take-home message is, if you have pain in your arm, you have chest pain or shortness of breath, go see your doctor. Could be coronary artery disease. But he sort of ignored those symptoms. His mother was smarter. She realized something was wrong, went to her doctor, and electively got the stent instead of having to be rushed down and, you know, be defibrillated. So one of the issues about coronary artery disease, and you come back to hear the talk on genetics, because I think one of the areas that we're making great progress is to understand the risk factors for coronary artery disease. Now, we know a lot about cholesterol. We know that eating the right foods is important, watching your weight, exercising, not smoking. Smoking is probably one of the worst things you can do. It certainly is a big contributing factor to coronary artery disease. But I think, you know, it's a balance between your genetics and your environment. And, you know, the environmental stress of cigarettes and bad foods and no exercise, that's a bad environment. But if you combine that with a bad genetic makeup, you're waiting to get coronary artery disease. So one of the things that Stanford has done very, very well, there's a guy here named Pat Brown who developed the DNA gene chip array. And that has really advanced our understanding of all kind of disease processes. And certainly the discovery now and the mapping of the human genome is going to really open up things for us to better understand which individuals are at a higher risk for coronary artery disease or other diseases. And we can talk about some other diseases later that this genetic information and technology is really going to help us in treating patients and really move us to that next level, which is not how we treat things, but how we prevent them. So coronary artery disease is certainly, we know that there are genetic factors that are involved with the development of coronary artery disease. And the latest treatments are less invasive surgery if you need it, and stents. And we can talk about in the Q&A session about the drug-coated stents. I'll just say that one of the issues with the stents without the drugs on is that about 25% of the stents will block and have restenosis after a certain period of time. And then you have to go back and get another procedure or go on to bypass surgery. The good news about the drugs being put on the stents, they inhibit the formation of scar tissue. The bad news is you have to take drugs like aspirin and Plavix, you know, at least for a year now, and maybe for the rest of your life, which could be somewhat problematic. But most people would take that. It's a catheter through the artery in the leg up to the heart, and you can go home in a day or so, as opposed to having a big heart operation that may take you a month or so to recover from. So that's what's going on with coronary artery disease. I would say the other area that Stanford has really excelled at and where we have great advantage is in the area of imaging. So with a combination of genomics and molecular imaging, which is using molecular genetics and molecular biology to be able to perform imaging study, which is more advanced in the area of cancer than in the area of cardiovascular, but we're catching up. There are great people here at Stanford that are on the cutting edge of using CT scans, MRIs, PET scanners. Guys like Jeff Rubin, Mike McConnell, and Phil Yang are really world experts in this area to be able, without having to have a puncture of the femoral artery and have an angiogram, just to get a simple IV, a little contrast material, and a quick picture with a CT scan. I actually had one, and it was in and out. It was literally a couple of minutes of scanning time with an IV. They took it off, put a Band-Aid, I walked out, and they're beautiful pictures. I'm happy to email pictures of my heart because my coronary arteries look pretty good. So that's coronary artery disease, and we can, we'll probably get into a pretty good discussion about that later. Valvular heart disease, the valves, the aortic valve and the mitral valve, can either be stenotic or they can leak. And stenotic is usually because of either rheumatic fever, or in the case of both the mitral and aortic, or mainly in the aortic, you're born with 2 cusps of the valves instead of 3. And over time, usually at about the age 60 or so, calcium builds up on the valve and it blocks. The valve is meant to be about that big, and it can get down to about the size of a pencil. And then people get symptomatic and we have to replace them. So those operations, I generally do those operations through fairly small incisions these days. Not all the time, it depends on what else I have to do. But the cardiologists, remember I told you the cardiologists are getting more and more aggressive. And now there are techniques through a catheter that goes through the groin, much like a heart catheterization, that you can actually take a balloon, blow the blocked valve up, open it up, and then a stent with a pig valve inside a stent that is compressed down and then opened up to replace the aortic valve without having an operation. No incision in the chest, just a puncture in the groin, go across. So this has been done in about 100 patients. And it's been done primarily outside the United States, a couple of cases in the United States, but it's not quite ready for prime time yet because the results have not been very good. But at least proves a principle that it can be done. And most of the patients that have had this procedure are patients that were turned down by surgeons. They were too sick to be operated on. So it's a promising technology to be able to replace the aortic valve without needing to have an incision or an operation. So that's the aortic valve. In the mitral valve, there are several companies now. The most common thing that happens is rheumatic fever we don't see a lot of. I was just in China a couple of months ago and spent a week over there operating. They still see rheumatic fever all the time, and when I was early in my training, we used to see more of it, and the hearts or the valves get really destroyed, and you have to cut the valves out and replace them. Most of the mitral regurgitation that we see today is based on changes that the cords that hold the valve in place either rupture or there's too much tissue, and we can simply cut it out and sort of do plastic surgery of the valve. We can repair the valve. And that's a big advantage because there's no good prosthesis. It's much better to have your own valve and have a bit of a facelift of the valve than to have to replace the valve, because there are two choices. There's a tissue valve, which is usually a pig valve, and the problem with that is that it wears out after a certain number of years and you have to have it replaced. Or there's a mechanical valve, and those valves, the problem with those is that you have to take blood thinner and you have to take them for the rest of your life. Otherwise you get clots and strokes from it. So repairing the valves, we try to repair every mitral valve now, and there's a guy in our department, Craig Miller, who's been funded by the NIH for 30 years. I think it's actually 25, 26 years now, continuous funding, and he's a world expert on how the mitral valve works, and he's taught all of the cardiac surgeons in the world about how the valve works and repair techniques that can be used to repair the valve. So we try to repair and save the valve in every case. But there are companies, the cardiologists, again, have developed catheters that can go inside the heart from a puncture in the groin and then use a variety of techniques to try to repair the mitral valve. There's a little clip called E-valve where you pull the two edges of the valve leaflets together to stop the leakage of the valve, and other things that are being developed that would avoid operation. Again, they're in early clinical trials and certainly not ready for prime time yet. Going back to the aortic valve and now talking about aneurysms, there's also an advantage to trying to preserve the aortic valve, just like the mitral valve. And there was a great case recently. There's a player who played basketball at Gonzaga up in Spokane, Washington, named Ronnie Terioff. He was drafted by the Los Angeles Lakers, and I don't know if Dr. Jerry Buss, the owner, is really a doctor. I don't really know his deal, but most all the professional basketball teams, at least now, get echocardiograms of all their players, because there have been famous cases of players having aortic aneurysms that were undetected, because you can't tell it from an EKG. If you're really smart, you can see it on a chest film. But they all get screening echoes, and they wouldn't sign this guy because he had this big aneurysm of his ascending aorta. So the aorta was about that big. Remember, I told you it's only supposed to be about an inch. His was about this big. And the valve leaked, although the valve leaflets were normal. So most of the time we require a big operation. We cut the valve out, we put a mechanical valve in, and we put a graft in. The problem with that is if he'd had a mechanical valve, he has to take blood thinner. He was in his 20s. If he had a pig valve, he'd have to be back and get a reoperation in several years. And so Craig Miller, again, has done about 200 of these cases where he completely resects the aneurysm and leaves the aortic leaflets in place and is able to put a graft there and reconstruct the aortic root, thereby leaving normal leaflets, no blood thinner, should last the rest of his life. And oh, by the way, he got to sign his multi-million-dollar contract, and he's playing with the Lakers, and everything's going well. I told Craig that I wish I could have negotiated that to get a piece of his contract, because without that operation, he couldn't play. But we're here just to help people, so we missed out. And he did very well this year, although the Lakers aren't doing so well. So that's sort of valve repair and valve surgery. It requires, obviously, cardiopulmonary bypass to stop the heart and change the valve out. So moving on to the aorta, I mentioned this aneurysm and how we have to repair the ascending aorta. A lot of the aneurysms are in the descending aorta, in the side of the chest. You would have to have a big operation, go through the ribs, take a rib out, replace the aorta with a graft. We use medical cloth called Dacron that's in a tube, and that stays there forever. But it's a big operation. There was a guy here by the name of Michael Dake, along with Scott Mitchell, one of my partners, and Craig Miller, who developed a technique of endovascular approaches, meaning that you could go again through a catheter and have a graft on a stent, put it inside the aneurysm, blow the graft up, and have the blood directed through the graft so that it wouldn't be pressing against the wall of the aorta. Remember, an aneurysm is an enlargement ballooning, it thins out, and the problem is that it can rupture, and usually within a couple of heartbeats the patient will die. So instead of having to have these big operations, more and more we're using these stent grafts to be able to repair aortic aneurysms and save people the problem of having a big operation and a long recovery there. Turning now to the heart muscle, and something that obviously Stanford is very famous for, and that's cardiac transplantation. We did more transplants, thoracic transplants. Again, thoracic means either heart transplant, a lung transplant, or a combined heart-lung. Dr. Shumway is a legendary father of cardiac transplantation. If you play on the golf course, he loved to play golf. The next time you're on the golf course, look at the tee box on number 12 on the red tees. Most people don't hit from the red tees, but go by there and look at it. There's a beautiful plaque that was put out there for him, and he was clearly recognized as the father of heart transplantation, and really developed it from the laboratory. It's one of the greatest examples of translational research in modern medicine. He spent 10 years in the laboratory developing techniques that finally brought the technique of heart transplantation to the clinic and did the first case here in 1968. So we've had a long and rich history in being the first to do things like putting a artificial heart in to bridge someone to keep them alive until a heart transplant could become available. And that was done first by Dr. Phil Oyer in 1984, who is still one of the faculty members here in the department. So the problem with the heart muscle and heart failure, there are 5 million people in the United States that have heart failure, 500,000 new cases every year. So it's by far the biggest in this group of cardiovascular diseases that cause problems for people. And it's primarily related to either a heart attack causing damage to the heart muscle, because a heart attack, the way a heart attack happens is if blood flows into a muscle, think about in your leg, if you tied off the vessel that goes to the leg muscles, you'd get a lot of pain in your leg muscle, and then after a while the pain would stop because the muscle would die, and the muscle can never regenerate and regrow. It turns into scar. Exactly what happens in the heart. That's called a myocardial infarction or a heart attack. The blood vessel blocks. There's not enough blood going to the muscle. The muscle dies. It can't be regrown. It can't regenerate, and you get scar there. So those are primarily diseases of the heart muscle, and the way we treat them, we try conventional operations. Medicines are good for treating heart failure. There's a subset of patients who can't be treated any longer with medicines or conventional operations, and the only option for them is to get a transplant. Now, it's estimated there are about 100,000 patients a year that could benefit from transplant. I think the number is probably more like 10 to 20,000, but a large number of people could benefit from a heart transplant. It's a supply and demand problem. There are not enough donors, not enough good donors that are acceptable. Even though we keep, the joke was always we would only use a donor who was about the same age as Dr. Shumway, and as he got older, we started using donors that were older and older. And we now generally will if there's a good heart in a 65-year-old, even 70-year-old that is a good heart, strong heart, we will use it. Certainly a lung, we do that. The problem is there are only about 2,000 donors in the United States every year that are good enough donors to be used for heart transplantation. So that leaves other options that we can explore for either treating heart failure or replacing the heart. And I alluded to a left ventricular assist device. It's really an artificial heart that is used to support the blood circulation. And there are a number of different companies that are using these pumps. And there's only one, though, that's approved for, quote, destination therapy or standalone therapy as an alternative to heart transplantation. Because remember, if you get a heart transplantation, you trade really one disease process for another. You trade the heart failure and dying for another whole set of issues, and those are rejection, infection, high blood pressure, the risk of cancer, because you suppress the immune system, and cancer cells are able to grow if you suppress the immune system. So I had a question over here right before I came up about, well, how long does heart transplant last? And heart transplant, if you think about in the take-home message about this, is that once you get a heart transplant, not only do you get these complications of all the drugs, the steroids and the immunosuppressive drugs, but your clock is ticking. And the 10-year survival for a heart transplant recipient, if you look at all the recipients that have received heart transplants, it's now over 100,000 people have had heart transplants. It's about a 50-50 chance you're going to live for 10 years. That's not very good, I don't think. And there's a lot of improvement that we can make on that. And we're certainly doing a lot of research into better drugs, into better manipulation of the immune system to try to make heart transplant recipients live longer. Interestingly enough, most patients don't die from rejection. It's more the complications of infection and other things that cause the heart to fail. One area that I've done a lot of research on is there's an accelerated coronary artery disease. So we kind of covered coronary artery disease. For some reason, the coronary arteries of these transplanted hearts will develop accelerated blockage. And it's unlike most of the coronary artery disease we see, garden variety coronary artery disease, that usually is focal. You get at branch points in the blood vessel, you get a blockage. Here with a transplanted heart, it sort of starts in the small vessels and works proximally, and it's the whole artery. And we don't understand it, but we think it has to do with some low-level immune response. But those are the reasons why heart transplants, only 50% will last for 10 years. In the last year or so, I've actually transplanted 3 patients who've lived for over 20 years with their heart transplant done here at Stanford, and 3 of them got retransplanted with new hearts, and of course the hope is they'll live another 20 years because they've had 20 years of immunosuppression and seem to be tolerating it all right. So those are the areas of diseases of the muscle and some of the things that we're doing to try to treat them surgically. There are other operations that are a little complex to explain, but the scar formation, some patients when they form scar the heart will stay small. Other patients, the heart has an aneurysm of the ventricular wall, a ballooning out, and the heart becomes big, and we can go in and cut that part of the heart out and again do some reconstructive surgery to make the heart smaller and beat better. That's called a ventricular reduction operation or a door procedure. But the most exciting area for treatment of heart failure lies with stem cells. And I said I wouldn't say much about stem cells, but I've done a lot of research with Irv Weissman, who again, if all things are fair in the world, Irv Weissman will win the Nobel Prize in Medicine for discovering the markers for stem cells, both in mouse first and then in humans. And he's directs the Stanford Stem Cell Institute and Regenerative Medicine Institute, and also heads the Cancer Center. But we've done work because there were some preliminary studies back in 2001 that suggested that adult bone marrow or cells from adult animals from the bone marrow, when injected into the heart, you can take a mouse or a rat and tie off the coronary artery. See, I can talk to you now because you know all this stuff. You can tie the coronary artery off, give them a heart attack, and then put stem cells in. And there was great hope from this one landmark paper that the heart would improve function. So we can take bone marrow cells out with a needle aspirate and then process them and inject them in the heart, and your heart magically will regenerate cardiac muscle. Well, Irv, who lives on the campus, we both live on the campus, he called one Saturday morning and said, "Did you see that paper?" And I said, "Yeah, you know, those guys beat us to it. I knew we could do that." He said, "That's absolute nonsense. It's biologically impossible. It's not true, and we need to seek to prove that it's not true." So it took us about 2 years. We then published a paper that sort of changed the changed the field of stem cell research in that most people now believe that adult stem cells, in fact, don't have the biological capability of developing into new heart muscle. And the great hope is that embryonic stem cells can be used, because embryonic stem cells do have, and that's what all your hard taxpayer monies at work for with the California Institute of Regenerative Medicine. $3 billion, $300 million a year for 10 years being given in grants to researchers working on human embryonic stem cells. And so that's the great hope, but it's only hope at this point. There's never been one patient in the world who's received embryonic stem cells. The problem is that embryonic stem cells can develop into every tissue in the body. That's one of the greatest assets of embryonic stem cells, and it's the greatest liability, because if you inject them into animals, they develop into every cell in the body, and they actually form tumors called teratomas. So you can't control them. So now, getting back to the genetic side of the story, we're trying to figure out what are the genes and cell signaling processes that allow stem cell A, embryonic stem cell A, to decide to become a heart cell, stem cell B, embryonic stem cell, to become a brain cell or a liver cell. And once we figure that out, that we can differentiate and direct these cells into the tissues that we want them to develop into, and then can control that process, then we'll be ready. I think that I did an interview with Ed Bradley a few years ago for 60 Minutes, and he kind of pushed me, well, when will that be? Well, I don't know. You can't predict the future, but I would say it's at least 10 years away before we'll be able to use embryonic stem cells in a clinical setting. But there are many people in all these buildings across the Stanford campus, and it's really been a magnet to attract scientists from all over the world to come to California because of the readily available resources and funding. And that's another plug to just educate you about funding. Research in this country the National Institutes of Health funding has dramatically decreased. And so we're more and more dependent on grants from foundations, things like the stem cell money that comes in, and philanthropic donations to help support our research because we're in a period of time where it's very difficult to get funding from the federal government. So that's pretty exciting progress that's been made in stem cells. I'll go back to the adult stem cell issue. There have been several studies, particularly in Europe, and now a couple in the United States, preliminary studies of patients of about between 100 and 200 patients, where adult bone marrow cells were actually injected into the heart in patients that have had heart attacks or damaged heart muscle, and we've seen some improvement. The problem is that after about a year, that improvement sort of goes away. But it's still encouraging that even though these adult bone marrow cells don't magically turn into new heart muscle, there's some response that's occurring, probably growth of new blood vessel called angiogenesis, or there's some so-called paracrine response, some magic response of cell signaling that's recruiting factors that cause the heart muscle to remodel or to beat more effectively. There's a study that's going on at Stanford, led by the chief of cardiology, who's an interventional cardiologist, Alan Young, and one of his associates, Todd Britton, who are enrolling patients that aren't candidates for stents or for bypass surgery, but still have severe coronary artery disease. And what happens is that they use a needle to aspirate cells from the bone marrow and then process those cells and put in a catheter in the area of the scar. So that's, I think it's an important study because we haven't done well-designed studies in a large number of patients. This is a multi-center study that will go across about 15 institutions across the country, Stanford being one of the leading institutions, and it will get data on about 3,000 patients. So I think that's very important because there could be something to adult stem cells other than growing into new heart muscle cells. I'm going to switch now to the electrical system. There are 5 million patients in the United States with heart failure. There are 2.5 million patients in the United States with atrial fibrillation. So the electrical system runs from a little center in the right side of the heart called the SA node. There's an electrical impulse that's fired, and then the atrium contracts. That's the lub-dub lub-dub, that's your heart beating. So it's the atrium contracting, that electrical system runs down to another node in the wall between the two pumping chambers and fires. And the atrium, the electrical system runs through the atrium, and it's a steady sinus rhythm, lub-dub, lub-dub. The condition of atrial fibrillation, the electrical circuitry of the atrium goes haywire. There's chaos, and you lose the contraction of the atrium. And what happens there is that once the atrium stops contracting, it becomes stagnant, and you get clot formed in the atrium. And you're at great risk, if you have atrial fibrillation, of that clot breaking off and going to your brain and causing a stroke. So the problem with atrial fibrillation is that you can control the rhythm, or you can control the rate of the heart with drugs. And if you catch it early enough, you can control the actual rhythm to keep patients into sinus rhythm. But there are, like I said, 2.5 million people who are either resistant to some form of medication or have been in chronic atrial fibrillation and have to take blood thinner, Coumadin. So there are operations that can be done through a full sternotomy on cardiopulmonary bypass to stop the heart, where we make cuts in the atrium or either today now use energy sources such as radio frequency or microwave energy sources to burn tracks in the atrium to interrupt these chaotic pathways and try to restore sinus rhythm. Again, the cardiologists have devices now that can go through the femoral artery. They actually go through the femoral vein and across the atrial septum, the divider between the two rooms on the top part of the heart, the atrium, and to use radio frequency or freezing to put lines around the atrium to block these pathways and try to restore sinus rhythm. So that's a very encouraging area of research and development, and it's now available to patients. And Stanford is one of the sites. Paul Wong is the director of the electrophysiology service here, and is leading one of the major clinical studies using cryoablation or freezing of the heart tissue inside the heart through a catheter to try to reestablish sinus rhythm. On the ventricular side, the pumping chamber side, there are more dangerous rhythms. The atrial fibrillation is dangerous enough because of the blood clots and the stroke that can occur. But just like the barber who had a heart attack, ventricular fibrillation, which means the heart doesn't squeeze anymore, but it just starts quivering because it's not getting the good electrical signal, and people die from that instantly. And that's what defibrillators are all about. You see them in airports now, in schools, in the ballparks. You should learn how to use one because you know, one of your friends, your family members may need it one day. But what happens there is you have to shock the patient. You've all seen this on TV. But that's ventricular fibrillation or ventricular tachycardia. There are now procedures to use defibrillators that are implantable under the collarbone, through the vein, into the heart. The device is able to detect the rhythm and to provide a shock. Soon, that signal is going to be transmitted wirelessly through satellites, and one will be able to sit in an office and look at the rhythm of someone's heart and be able to not have to come into the office and get checked. So those are sort of the latest developments in the area of ventricular and atrial rhythm disturbances. And then finally, I'll just say a few words about congenital heart disease. As I said, 50 years ago, those were the first cases, and Dr. Shumway was actually at the University of Minnesota as a trainee and watched the first congenital heart surgery, the first heart surgery operation ever. And the way that before the cardiopulmonary bypass machine was invented, one of the parents would actually have a cannula is a tube, placed in the femoral artery, would be asleep, and a cannula placed in the child's femoral artery, and the parent served as the heart-lung machine for the child so that you could do the operation. And Dr. Shumway was actually there in the early and mid-50s to see these first operations. And then Stanford was lucky enough that he came here and continued. He was not only a great transplant surgeon, but he was a great congenital heart surgeon, valve surgeon, aortic surgeon. All this stuff was built. It can show you how the difference one person can make to an institution. But there are certain things that people are born with, such as holes in the heart, holes between the two upper rooms of the heart, the atrium, are called atrial septal defects. Between the two bottom pumping chambers are called ventricular septal defects, or VSDs. There are connections between the aorta and the pulmonary artery called patent ductus arteriosum. There's tetralogy of flow. There are a lot of different things that can occur that are congenital abnormalities. The good news is the heart-lung machine has gotten better, the surgical techniques have gotten better, and most all of these things can be corrected with a very low risk to the patients. Just like with all the other things that I've mentioned, surgery has been the mainstay and the gold standard for fixing these. Now, today, cardiologists with a catheter can put a little device, a little umbrella device in between the atrial septum to close a hole in the heart. And that's with a Band-Aid on the groin, go home the next day. There are coils and little devices that can block the connection between the aorta and the pulmonary artery, the PDA, so that we don't operate on those cases anymore. So that's a case where children are saved in operation and can grow up to have fairly normal lives. On the more invasive side, and probably one of the fewer areas that we can think of that surgery can be more invasive, and again the cardiologist got into this story, is that Frank Hanley and Mohan Reddy are two of the world's most premier heart surgeons work in our department here at Stanford, have had, much like Shumway, have had 10 years worth of research into looking into the, again, using the mother and the placenta as the heart-lung machine, and actually going in and trying to repair some of these complex defects in utero, then putting the baby back, in this case a small lamb back, and surviving the patient. And Dr. Hanley has actually, here at Stanford, done one operation like that in a human, to actually try to repair the defect in the uterus, because the thought was that the baby may die. So those are examples of things that are being done on the surgical side for congenital heart disease. So in the last couple of minutes that I have, I just want to talk about a couple of things. One, the future. I think that this valley was built on incredible technology around computers and engineering feats, and I think that the rapid acceleration and development of technology. I mean, now you can basically, fly with a little PDA. You can cook breakfast, remotely or whatever. My wife just got an iPhone, and the thing is tremendous. I mean, it's just, I'm not a Mac person, but it's great. I might become a convert. But I think the next wave of the rapid advance that you're going to see is going to be in the life sciences. And that has to do with the fact that the human genome has been discovered. There's now very inexpensive, high throughput genomics that will be able to tell us if you will be able to respond better to one blood pressure medicine versus the other, how your genes affect what diseases you will have. It gets a little bit scary because you don't want to get in the situation where at age 10 you're known that you're going to have colon cancer, so nobody's going to insure you, right? So there are a lot of things that have to be worked out, but I'm very convinced that this is the next wave of major technological advance is going to be in the life sciences. And as I've outlined before, it's going to be around high throughput genomics, it's going to be molecular imaging, it's going to be newer drugs that are targeted from the basic research we do. And I think we're moving toward an area and an era when we're going to be talking about preventative medicine, predictive medicine. It's going to require participatory input from the patient and family, and taking responsibility for the disease process. I mean, the epidemic of children that we're now raising, that the level of obesity is just dramatic. We've got to get some control and better educate people about their diet. It's not just cholesterol, it's HDL. You want your HDL to be as high as you can get it. You want your LDL to be as low as you can get it. There's homocysteine, there's LP(a). There are all these things that need to be monitored and paid attention to. Blood pressure control. All of these things we need to educate our patients about and get in the mode of not these novel new cutting edge treatment modalities, but how can we predict and prevent these diseases. So the final thing is that Pat mentioned, that I do direct the Cardiovascular Institute, which is really a university-wide initiative that seeks to bring together basic scientists, cardiac surgeons, cardiologists together to try to work on bringing some of these cutting-edge basic science discoveries into the clinical realm to improve the lives of our patients. And so there are three main objectives that I talk to people about trying to help support with generous philanthropic funds. And those three areas are our education and research programs. We try to have seed grants that we can stimulate young investigators before they can get funding from the NIH, and sometimes older investigators who've run out of funding from the NIH and can't get it, to provide them with bridge funding or seed funding to stimulate them to come together in ways that they wouldn't have before, to try to solve some of these big problems. In educational efforts, Dean Pizzo in the School of Medicine, the School of Medicine has always been sort of a de facto 5-year School of Medicine. Most schools are 4 years. And you can think of the scholarly concentration program that the Dean introduced a couple of years ago as sort of a major, a medical school major. So you come in and you do 2 years of basic science and 2 years of clinical science, and you pick an area such as immunology or public health and cardiovascular, neurosciences, and you spend a year of immersion in that area. And so we as the Institute try to support educational programs there that cost money. There's a new medical school campus that will be right down the street here and to the left. You probably don't know, where is the medical school entrance? Well, it's hard to find. It's not well, the signage is not good, but in a couple of years you're going to see a dramatic change. You can see some of the construction that's going on. There will be a new Learning and Knowledge Center created with a new entrance into the medical school, and the Learning and Knowledge Center will house a library. It'll house a big auditorium, so during the rainy season we can go inside and have nice lectures like this. There'll be computer labs and there'll be simulation labs. This is a big thing that the surgeons have been way out in front on, but Dave Gaba, who's an anesthesiologist here at Stanford, is really a world leader in simulation. And the idea is that we can teach our young trainees how to do some of these complex procedures with computer simulation and other simulation, much as the airline industry is taught pilots to fly before they actually take you up in a 747. Difference, of course, is that when things don't go well for me, my patient may not do well, but at least I get to go home. Pilots, when it doesn't work out for them, they don't get to go home either. So it's a good model to use for training young surgeons. So we're creating new research buildings to house the Stem Cell Institute, the Neurosciences Institute, the Cardiovascular Institute, and that'll be along this new campus, medical school campus that's just down the street. And then finally, Dr. Shumway had people come from around the world in the 70s, early 70s and into the 80s to see how you did heart transplant, because he was doing heart transplant when everybody else in the world, all the great cardiac surgeons, said it'll never work, it failed. He was the only place that continued to persevere and push things along. We're still using those same ICUs that we used then 30 years ago. So we're in desperate need of new facilities. I often say it's like, why did the Giants need a new stadium? The team wasn't any better, but people will come, and we need a new stadium. We need a new hospital, and luckily it's in the process. There'll be a brand new state-of-the-art facility built hopefully within the next 10 years out in front of the current hospital. It'll be a 600-bed facility, and of course I'm going to be advocating and trying to raise money for a heart hospital that'll be a hospital inside a hospital for the latest catheterization labs, operating rooms with robots, and where we can work with the cardiologist to do percutaneous and minimally invasive operative procedures, state-of-the-art state-of-the-art ICUs and units and imaging facilities, because the CT scanners and MRI scanners that work for the heart are not exactly the same that work for the brain. So that's a major initiative that all of you need to know about, because it's an incredible luxury to have a world-class hospital like Stanford in a community like this. So I'll conclude there. I'm glad that you all came out tonight, and I will be happy to answer any questions you may have. The question is, first of all, diabetics, and I didn't cover this in the coronary artery part, but diabetics do not respond well to stents. They have a higher incidence of restenosis and blockage off of the stents, and oftentimes the arteries are really small. The bigger the arteries are, the better the stents work. So in diabetics, the disease is usually very diffuse, and the restenosis rate in the stents, even the drug-eluting stents, are too high. So the best therapy, it turns out to be actual bypass surgery for diabetics. Certainly with 3 blockages. There's a main right coronary artery, and then the left side there's a main left coronary artery that branches into 2 branches. And so that's the traditional, as Dr. Shumway said, used to say, the usual 3, meaning 3 bypasses or a triple bypass. That means the right coronary artery and the 2 main arteries on the left side are bypassed. The most I've ever done is 7 bypasses. And in diabetics, oftentimes, you need to use multiple grafts. And the use of arterial grafts, particularly the artery under the breastbone called the internal thoracic or internal mammary artery, the radial artery out of the arm, you can still perfuse your hand with the ulnar artery, and we take the radial artery because the arteries last longer than the veins. The veins will usually, after 10 years, it's the same with transplants, after 10 years the veins will usually block off in about 50% of the cases. So we try to do all arterial bypass grafting in diabetics. The second question was about Berkeley Heart Labs, and when I was rattling off all those, you could probably Google Berkeley Heart Labs and find out what that's all about, but they provide very sophisticated testing. When I was talking about HDL, LDL, cholesterol, homocysteine, Lp(a), platelet particle size, all of those things are very sophisticated tests that Berkeley Heart Labs can do off of one blood sample. And they are predictive because there are a lot of people who have, particularly even, I see patients from, East Asians that are vegetarians, they live a great lifestyle, and they have some of the most horrific coronary artery disease that you can imagine. Many times there are obviously genetic components to it, but there are other things like homocysteine and other things that can be treated with medicines. But at the end of the day, certainly for the diabetics and diffuse coronary artery disease, bypass surgery seems to be better.
Could you go into the what you think about the medicated stents? I was just reading a Science News article about it. It seemed like they were comparing apples and oranges because they were comparing statistics from people that were using medicated stents that were not supposedly supposed to use them there, with people that were using the stents where they're supposed to be using them, and the ones that were supposed to be using them where they were doing very well, and the ones that where they're using them other places were not doing well.
Okay, that's a good question. So I think there's been a lot, and it's the great hope of the cardiac surgeons that there used to be about 1 million bypass operations done a year. Now there's about 300,000. And balloon angioplasty used to be about 100,000. Now there's 1 million. And so when this data came out, all the cardiac surgeons got really excited because we thought it was the end of stents and, bypass surgery is back and we get to do these big operations again. I really think, though, that the small amount of thrombosis that occurs with these drug-eluting stents is exactly what your question is getting at. And that is, use them in the areas of blockage that are most suitable for treatment, such as not long lesions, not in small arteries. So if you have long complex lesions and multiple complex lesions, or if you have diabetics with small vessels and you try to cram a stent in, no matter if it's got drug on it or not, they're not going to do as well. If they're isolated blockages, like I said before, most of the coronary artery disease is at the branch vessels, and it's isolated. And if you have a very short, isolated segment, I think stenting is great, and the drug-coated stents are going to work well. It's when you try to push the envelope and keep the patient away from the surgeon, and patients don't want that. If I ask you, would you like to have a stent, or would you like for me to open your chest up? And the cardiologists in the lay press always say, crack the chest. I've never seen the chest cracked. I think of like cracking a nut. Or do you want a big operation? I saw this asked at a group of, the leading cardiac surgeons in the country. We have these debates between cardiologists and surgeons. Everybody raised their hand, I'd rather have a stent. But if you know that the stent is going to be tried to be used in a case where there's complex and diffuse disease and diabetics, then I think you're going to see that bypass surgery is actually going to have a little bit of a resurgence, and it's a better treatment modality.
Dr. Robbins, with the technology of cardiac pacemakers and ICDs now being available for resynchronization therapy, is the technology too early yet for you to be seeing changes in cardiac remodeling, and is that impacting your patient profile that are going on for more chronic heart failure needing alternative therapy?
That's another excellent question. You guys did your reading and homework before you came. So you hit on something that I forgot to mention, and that had to do with the electrical circuit of the heart. One area where pacemakers obviously are used is for heart block or slow heart rates. The defibrillators that I talked about were for the chaotic rhythms. So the resynchronization is a very interesting thing. It turns out that, and that gets a little bit technical in that if you have a long QRS interval there, then and the patient's heart doesn't work very well, there's a cardiomyopathy. And I didn't tell the story earlier that I had to tell. There's a great story of a 21-year-old that has come to Stanford to actually get a defibrillator and be resynchronized. So resynchronized means that the electrical signal is going to one side of the heart and not to both sides at the same time. So these pacemakers, it's a combination defibrillator pacemaker. And it's usually patients that have enlarged heart, and in this guy's case, he's a 21-year-old rugby player from the UK who came over, and he was playing on a professional rugby team, and he noticed that he couldn't keep up. He just was getting more and more breathless as he was training. He was this big, strapping, good-looking guy, and he got a chest film. Somebody in Santa Cruz got a chest film, and your heart, it really is about the size of your fist. His heart was the size of a volleyball. And this is a strong, good-looking guy, and he came to get a defibrillator, and I was sitting in my office one day, and they called to say you got to get over to the catheterization lab, because when you put a defibrillator in, you test it. And the way you test it is you take the heart that's going lub-dub, sinus rhythms, going along well, and you actually induce fibrillation. So the heart stops and it's fibrillating, and then you shock it, and then it goes lub-dub. Well, they induced the fibrillation. His heart started quivering, and they couldn't shock it, couldn't get him out of it. So they were doing CPR, and I rushed him to the operating room and put one of these artificial hearts in, LVAD, and he came out and he lived, and then in about 6 weeks he was able to get a heart transplant, and then he went on to to go back to the UK, and he ran the London Marathon back in the spring. So that's a great story. The problem is that we have no idea what caused this 21-year-old's heart. He had normal, you know all this stuff now, right? He had normal arteries. He had a normal looking muscle. He had normal electrical system. He had normal valves, but the muscle just didn't work. And that's one of the big areas that I'm very interested in, and we're using the power of genetics and molecular imaging to try to understand this issue. So now, after I've worked my story in, I'll get back to your question, which was, how has that been successful? So we have a conference we had it today, Thursday, and it's sort of a tumor board, if you will, for heart disease. in cancer, they bring together the radiation specialists, the chemotherapy specialists, the surgeons. And we do that in cardiac disease. We bring the electrophysiologists, surgeons, cardiologists together. And what we've seen is that in these dilated cardiomyopathies with resynchronization therapy, about a third will get better, about a third will stay the same, and then sometimes patients get worse. So I think in the right subset of patients, resynchronization therapy can work. We're still getting data and more long-term follow-up to be able to predict this is a good patient to have resynchronization therapy. Yes.
Yeah, left bundle branch block. Can you tell us what that is and what the implications of it are?
So if you go back to the electrical system, this is where slides help, because I can show you the diagram. It's like an old Jaguar with a bad electrical system. It's in the septum between the two pumping chambers, the right ventricle and the left ventricle. There's so it starts out in the atrium with the first electrical impulse that then travels across the atrium to a node for a second impulse. That's the dub. It's the dub part, and then that splits into two fibers. It's called the bundle of His. It splits into a right bundle and a left bundle. Left bundle goes to the left side of the heart. Right bundle goes to the right side of the heart, and that's where some of this resynchronization stuff comes in. Sometimes you get a disruption in that electrical circuit in one of these bundles. And if it's on the left side, you get a left bundle branch block, meaning that the right ventricle is going to contract first, and then the electrical signal comes around, and then the left ventricle contracts later. So that's where some of this resynchronization, you put it's not exactly what happens, but it can be useful, where you put an electrode in the left ventricle, and then you synchronize these two bundles back together. So left bundle branch block usually is something that you have to keep an eye on, but the right bundle works and you don't need a pacemaker. But there are some cases where if you've got progressive prolongation of the interval between the sinus node and the AV node, that you would need a pacemaker. But isolated left bundle branch block is okay. Yes.
Dr. Robbins, didn't Christian Barnard in South Africa perform the first heart transplant?
Actually, if you want to be technical, my mentor in Jackson, Mississippi in 1964 performed the first human heart transplant. His name was James D. Hardy. And I was telling Pat this story earlier because she knew Dr. Shumway really well. And you're right, the first human donor to human recipient was Christian Barnard, who was actually a resident with Dr. Shumway back at University of Minnesota. And Pat relayed the story of a couple of days before Barnard did the operation, he'd come over and he had watched Dr. Shumway and he'd watched Dr. Lauer. There's a great book that I have that this guy, Don McCrae, wrote about Every Second Counts. It tells the story in detail about the race. It was like an arms race to do the first heart transplant. So Dr. Barnard calls up Dr. Shumway a couple of days before, and of course he didn't tell him he was going to do it because he knew Shumway was about to do the first, and he kind of scooped him, and he was asking him some last-minute questions, and so Dr. Shumway helped him. And I was telling Pat this story, Dr. Shumway was always fine with Barnard doing that first transplant. It's all in this book, but he quit operating. He was sort of a one-hit wonder. He became a celebrity. He dated all these movie stars and traveled around the world and ended up selling anti-wrinkle skin cream. And Shumway, of course, went on to become, the master of the world of heart surgery. Dr. Shumway used to show the slide a little tongue-in-cheek, and you'd have to know him to appreciate this. I've forgotten the name of the movie star, Gina Lollobrigida or somebody, that he was walking down this beautiful boulevard in the spring. She was on Christian Barnard's arm, and Shumway would put that picture up and say, Dr. Barnard doesn't do surgery anymore, but as you can tell, he's still operating quite well. So you're right, he was the first to do it. But James Hardy, I get back to this 1964 in Jackson, Mississippi, he used a chimpanzee heart into a human who was dying. And of course that didn't work out very well, but if you go back and look at the New York Times, they plastered it all over the New York Times, and that was the first. It's in the book, Every Second Counts. So the question is, would stem cells help an enlarged heart due to rheumatic heart disease? And I would say that would be probably, if stem cells work, which we think there's great promise for them. I went through, what I think is probably the most plausible thing is in patients with scar in the heart to regrow new heart muscle require embryonic stem cells. Although there's a recent paper that shows that you can take skin cells and reprogram them, and they're two important genes, and I think maybe Mike Longacre would have covered this, but can reprogram these stem cells so that they act like embryonic stem cells and then can differentiate into it. You have to figure out all the details, but that gets us away from some of the moral and ethical issues of embryonic stem cells. But I think that for rheumatic heart disease, most of the time the problem is in the valve. And I don't think that stem cells, I think it'll be applied first to the patients who have heart attacks, and secondly, potentially to these patients with, like the young rugby player who has dilated cardiomyopathy. We don't know what the cause is. Most people think it's probably a genetic predisposition with the environmental stimulus being some sort of viral infection. So if you could figure all that out through genetics and genomics, then you could potentially immunize patients with that genetic makeup to a certain virus and prevent that from happening. And that's about half of the heart transplants that we do are for idiopathic, meaning we don't know what causes it, dilated cardiomyopathy. So I don't think stem cells are going to work for rheumatic heart disease. One of the areas that I forgot to mention, and I thought I might get a question about, is the whole area. There are 5 strategic areas in the Cardiovascular Institute, one of which is women's cardiovascular health. And it's particularly troublesome to me that there are women that have coronary artery disease that don't have the typical findings of the barber who was ignoring it with chest pain and pain down the arm. Most of the time, coronary artery disease in women presents with atypical patterns. Moreover, there are certain diseases such as idiopathic pulmonary hypertension, and that's high blood pressure in the pulmonary arteries, that is predominantly a disease of women. And we have no idea, just like idiopathic. Idiopathic means we don't understand the cause for it. Idiopathic dilated cardiomyopathy, idiopathic pulmonary hypertension, predominantly a disease of women. We don't know why. So we're doing genetic and imaging studies to try to figure that out. But there was just a paper recently that showed yet another example of how hormone replacement therapy is probably not a good idea to prevent heart disease, and can, there comes a patient. Yeah, we're done now. That it can actually increase risk of blood clots and actually make cardiac symptoms worse. Marcia Stefanik, who has given many talks in the community here, is really a world's expert in this area, and we've got a lot of things that are on tape that you can, and if you ever get the chance to hear her talk, she's really an expert in this area. Yes?
You mentioned with heart transplants that you're trading one disease for another because of all the drugs that you have to take.
Right.
What is the future of that? Are there new developments on the horizon, and what's kind of timeline?
Yeah, I think there are 3 kind of areas. One is better drugs, because right now the drugs, even though we've been at this, Dr. Shumway's transplant was in 1968, and that was one of the problems with Bernard. He came over, saw it. Like all the great cardiac surgeons, they thought it's actually a pretty easy operation. It's probably the easiest operation we do. The details are the problem, and that is the immunosuppression and the monitoring for rejection and all those things that Shumway and his team, and another thing is he just wasn't a cardiac surgeon. He built this great multidisciplinary team to tackle this real big problem. So right now, there are drugs that are sort of 3rd-generation drugs that are more specific for the immune system. In the early days, it just wiped out the whole immune system. It was almost like irradiating the immune system. So all the patients didn't die of rejection, they died of infection because they had no immune cells to protect them from infection. So as we get more educated in this high throughput genomics, I keep coming back to that because it's going to change every part of medical care and scientific research in the biological sciences, is that now we can develop better drug targets so that the cells that are the immunologic cells responsible for rejection can be targeted through mechanisms that don't bother the cells that prevent infection. So that's one area. Better, more specific drugs. I think we over-immunosuppress people, and that's why we get complications of cancer and infection still. Hypertension and all the hypercholesterolemia. I mean, it's like creating a milieu for, coronary artery disease. Secondly is that that there are going to be better and better, smaller and smaller artificial hearts that are developed. There are now heart pumps that, the ones that we put in now, the one that Phil Ory used in 1984, the Novacor left ventricular assist device, is about this big. It'd be too big for you, couldn't put it in you. But now there are sort of third generation heart pumps that are about the size of a D battery that can be put into the heart. And the key there is that we need to get those devices to last longer. So that we actually replace transplantation with these devices. Once these devices are totally implantable, it would be like putting in a defibrillator. If you had a little heart pump that you could put inside the heart that could pump blood and it was totally implantable and it lasted for 10 years, we wouldn't do transplants anymore. And I actually think that has great promise. So those are the two areas that I see. And then finally, the Holy Grail in all of this is the induction of tolerance. And tolerance means that you make some third party, some unrelated person who gives you their heart, makes your immune system, tricks your immune system to believe that that tissue is actually your own tissue. And you don't have to give any immunosuppression. And so there's a lot of work going on at the level, genetic level, at the level of the immune system to try to trick the immune system to accept that heart or kidney or liver or skin graft without any immunosuppression. Still won't solve the donor supply, and I think that's why mechanical heart and stem cells have greater promise. Yes. The question is more about the robot. So in my opinion, for using, there are a couple of uses right now for coronary bypass and for valve surgery, primarily mitral valve surgery. And it's pretty good for that because you can sit at a console and the robot's over there and the patient's over there and you can see, and the visualization is outstanding. And the company that is really the leader in this area is called Intuitive Surgical, which is, it started out in Mountain View. I think it's now down in Sunnyvale. But it's actually a lot of fun and it's really easy to do, and you can, the advantage is it comes through small ports instead of an incision. But most of the time, especially if you're replacing the valve, you have to make a small incision because you have to get the valve through there. But I think that most all of that can be done through a small incision without the robot. There's a little bit of hype going on there. It's I think where it's made a huge difference is in some of the general surgical procedures and radical prostatectomies. It's really because the visualization is so good, sparing the nerves, and now I'm pretending to know what I'm talking about, prostate surgery. But that's where there's been a big growth in the use of robots. For coronary artery surgery, it's for taking down the mammary artery. What we do now is we do a big sternotomy, we open up the sternum, and there's a blood vessel that runs on either side of the breastbone, and we, under direct vision, kind of take that away from and divide the clips, take it away from the sternum, and then use it freely to do bypass. If you do that operation that I mentioned to you at the first of the discussion through a small incision, it's very hard through that small incision to get the whole mammary artery down. But if you use a robot, you can actually sit here at a console and you can use the arms to take that mammary down because you can see it so much better than you could through the small hole. Then you can either try and sew it onto the heart, but at that point you make a small incision and you just sew it under direct vision. But there is, and just to have full disclosure, I helped to start a medical device company that is working on connectors. And it's called Cardica, and the way that blood vessels, instead of sewing the blood vessels, you actually load up either the vein or the mammary artery or the radial artery onto this little device, and you actually put it inside the coronary artery and press a button, and it's all connected just like that. So that's where I think that it's going to, the enabling technology to be able to do no incision just through ports is going to work, and the robot's going to be very important for taking down the mammary and to stabilize the heart. Yes?
Yeah, when you said that atrial fibrillation is precursor for a stroke, were you talking about something more than paroxysmal atrial fibrillation, or are you talking about PAT?
Yeah, I think that that can be dangerous. It depends on how long the interval is between having sinus rhythm and how often you're flipping back and forth. I think if you stay in atrial fibrillation long enough, you're going to get a clot that forms in the atrium. And then if you go back into sinus rhythm, the atrium's doing this, there's a clot up there, then it goes boom, and it goes, the clot, now I'm sounding like John Madden, and boom, and it goes out there. But the clot can get expelled out of the left atrium through the mitral valve and out and cause a stroke. So it's a problem with both, but most problem with chronic atrial fibrillation, because the atrium gets really big, and particularly in the atrial appendage is the site where there's most stagnant blood flow. So there are companies now that are using small devices and even catheters to kind of tamponade the orifice to the atrial appendage, so it closes it off and clot can't form there. So you don't have to take Coumadin.
Good evening, Dr. Robbins. I noticed that a lot of your examples were based on younger people. Do you have anything you can say about what, the topic of your talk as it applies to senior citizens? Is there, or do you make no distinction?
Well, most of the patients that we operate on, if you look at our payer mix, if you will, it's Medicare population. Over 50% of the patients we operate on are over 65 years of age in the adult side. Obviously, the pediatric side are patients under 18. But I could have easily given an example of, last year, within a month's time, I did 3 ladies who all had aortic stenosis through a small incision in the top part of their sternum. They were 89, 91, and 93, had their aortic valve replaced out of the hospital in a week. So I think these less invasive operations are actually more efficacious for the elderly, because as you get older, then the chance of having a stroke with the use of cardiopulmonary bypass increases. Are there any other specific things? I mean, one of my mentors, James Hardy, and the University of Mississippi used to say, elderly patients tolerate operations just fine. They just don't tolerate complications at all. So if everything goes smoothly, you're okay. And I think that's why the less invasive operations are much better.
Is the surgery, the operation that you just described on the aortic valve, is that the same one that there was talk in the paper about Alta Bates Hospital, someone coming up with a new up there?
I'm not sure. I didn't see that about Alta Bates, about new idea, but I think it's probably using a less invasive incision, something that we've been doing here for over 10 years. And so I don't know how new it. Maybe it's new for that person.
Yeah. How do you advise your patients on whether to get a pig valve or whether to get a mechanical valve?
I usually, it's a personal decision. I can't make that decision for the patient, but I present all the options, and it usually hinges on, this is a catch-22, an avoidance complex, right? The plane's crashing. Do you go down with the plane or do you jump out? It's not a very good choice either way. But with a mechanical valve, the good news is you never have to have an operation again. The bad news is you have to take blood thinner the rest of your life. With a pig valve, depending on your age, you don't have to take blood thinner, but the chances are that valve is going to wear out and you have to have another operation 20 years later, 15 years later. So you get to choose. Neither one's a great choice, and that's why valve repair is always better, because that should last you the rest of your life. You don't have to take blood thinner and the valve doesn't wear out. So I use age. I kind of say 65 is sort of the cutoff. If you're 65, I always ask you, how long do you want to live? If you say 100, then I go, well, maybe a mechanical valve, but I would suggest, because the problem is if you put a mechanical valve in a 75-year-old and they do great for 10 years and then they fall and break their hip and they're on blood thinner, that hip break, fracture becomes a major issue because it bleeds. So I think 65, 70, because we're all living older, we're not going to retire at 65 anymore. We're going to be retiring at 75 or 80. And so, the age keeps pushing up, but it's a personal choice.
Well, no one wants surgery, but if you had aortic stenosis and you knew that somewhere down the line you might need surgery, at what point do you decide that because you're young and strong to do it then?
That's another very good question. First of all, imaging. I come back to imaging, and we've got great imaging at Stanford. And so, you want to do it just at the right time, right? You don't want to do it too soon because, it's unnecessary. And if you choose a pig valve, then that's going to wear out sooner than if you waited. So you want to get it just in the sweet spot of where the stenosis is enough that we know that you have a risk of sudden death, ventricular fibrillation, or heart failure or coronary insufficiency and a heart attack. And so that tends to be with a gradient across the valve of about 50 and a calculated area of less than 1 centimeter square, usually less than 0.8 centimeters square. So we actually have some objective guidelines that help you decide when it's the right time. You obviously want to be operated on earlier. We just covered that. The older you get, the more complications, and particularly stroke are an issue. But I would say, try to prevent having an operation as long as you can, but not too long. Sort of the Goldilocks. Not too hot, not too cold. And, all of these things, all these questions, consult your doctor, find a good doctor, talk to them about all these issues.
Okay, let's give Dr. Robbins a big hand. Thank you so much.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.